Hello, good morning and good afternoon, everyone, and thank you for joining today's webinar on From Planning to Action, Financing Quality Across the Health Sector. Before we get started, I just want to go over a few quick WebEx logistics for today's event. Firstly, this webinar is being recorded. We also have two main ways that we can use audio for today. You can connect using your computer audio, or you can connect using the WebEx Call Me feature to receive an automated phone call from WebEx. We absolutely anticipate questions and comments today, so we do want you to use the chat panel on the right-hand side to submit those questions and comments. Make sure that it's selected for everyone in the dropdown so we can share our comments and questions with everyone as well as our panelists. And if you just want questions to go directly to panelists, you can go ahead and change that toggle in that dropdown and select all panelists, and we will make sure that our panelists are seeing those questions and addressing them during our Q&A section towards the latter half of the event. But at this time, I'm going to pass things over to Lisa Maniscalco to get us started.
Great, good morning. Excuse me, good morning, good afternoon, good evening. I trust that my sound is working just fine. If not, somebody will give me a signal. Thanks so much, Miriam. And again, greetings. Welcome to everyone who has joined us for today's webinar on financing quality across the health sector, moving from planning to action. I am Lisa Maniscalco. I am a program management specialist and lead of the quality team within the Office of Health Systems in the Bureau for Global Health. And I'm just going to help set the scene for today's webinar and also provide some brief closing remarks. Our webinar this morning is hosted by the Local Health System Sustainability Project, also known as LHSS. This is USAID's flagship project in health system strengthening, led by APT Associates. So first, I'd like to provide a brief overview of USAID's foundational framework and how USAID approaches quality. USAID's Health System Strengthening Vision 2030, which was launched in 2021, draws upon the progress over a past decade and new challenges that have arisen, while affirming USAID's longer-term goal of worldwide resilient health systems. In terms of our operational approach to improving governance for quality healthcare, we define a quality health system as one that is responsive to population needs and utilizes continuous process improvement to consistently provide safe, effective, and trusted healthcare and medical products to improve and maintain health outcomes for all people. USAID works to enhance health system quality at all levels of the health system through a range of interrelated intervention areas. These include supporting country-led strengthening of health system governance and leadership structures and processes across the public and private sectors, supporting health system managers and community leaders to apply quality improvement methodologies, institutionalizing continuous quality improvement for healthcare delivery and health worker performance, strengthening the pharmaceutical system, including the regulatory system and pharmacy practices, to ensure access to and appropriate use of safe, effective, quality assured, and affordable essential medical products and pharmaceutical services in both the public and private sectors. For a little bit of background on this work that will be presented today, in a prior activity, LHSS conducted a study in 37 countries to analyze progress, strengths, challenges, and gaps as countries develop, implement, refine, or sustain their national quality policies and strategies. We also call this NQPS for National Quality Policy and Strategy. So looking at the strengths, challenges, and gaps as countries develop, implement, refine, or sustain their national quality policy and strategy, and other governance structures or mechanisms to support quality improvement and quality assurance activities in the health sector. The study provided insights into the challenges and successes of creating and implementing an NQPS in various settings. Given that no two country health systems are the same, there is not a one-size-fits-all solution to quality. And this study provides insights into the various methods by which the issue of embedding quality in the healthcare system is being addressed globally. So for today's agenda, our webinar will explore the purpose and value of national quality policy and strategy, how they can be used and applied in different country settings. I think we can go to the next slide, please. The webinar is based on the Health System Strengthening Practice Spotlight Brief, which shares a name with this webinar and was included in the webinar invite. The brief is one in a series about health system strengthening approaches that can be used by implementers in the field. And we encourage you to visit USAID's website to review and download the other briefs. I think if we go to the next slide, we might have the link. Okay, well, if not here, then here we go. There's the link to where you can find the brief for today, as well as other briefs that have been published. And we'll share that link again at the end of the webinar. So I will start off by introducing, excuse me, the webinar will start off with an introduction of the presenters by Anna Wadsworth, Program Management Officer with APT Associates. And then next, during the implementation considerations section, we will hear from in-country experts from Liberia and Rwanda and discuss their response to the following questions. How can we create a costed quality plan or strategy for all of the work happening across the country? When should we focus on internal financing methods, insurance, for example? When should we focus on external financing, for example? How can we create a plan for oversight and accountability that spans from the front line to the national level? We should have a good amount of time for questions and discussions at the end of the webinar, and we certainly invite each of you to raise your questions. As you follow along with us today, please go ahead and share your questions, challenges, and thoughts in the chat, and our in-country experts will have a chance to review them and share their reflections and feedback. Again, thanks so much, everyone, for joining us today. And Anna, over to you.
Thank you so much, Lisa. My name is Anna Wadsworth. I am a project management officer with APT Associates, and I'd like to welcome you all today on behalf of LHSS. We are so pleased that you've been able to join us. You've just heard from Lisa Maniscalco, who will also be providing our closing remarks, and I would like to quickly introduce our other webinar speakers. Morgan Stanzler is a project director with the Institute for Healthcare Improvement and will be moderating the implementation considerations portion of the webinar. She's joined by Dr. Christine Mudaganzwa, reproductive maternal and newborn health technical advisor with Chipaigo, Rwanda, and Dr. Anderson Flomo, a national clinical coordinator for healthcare quality and patient safety with Liberia's Ministry of Health. Dr. Sham Syed from the World Health Organization was unfortunately able to join us today. Dr. Soji Teddy, Vice President of Global Health with the Institute for Healthcare Improvement, will be stepping in to provide some reflections on financing quality across the health sector. So thank you again for joining us, and Morgan, over to you. Hi, Morgan, you're on mute, unfortunately.
Yeah, Morgan, it looks like you're unmuted, but we can't hear you.
How about now?
There we go. Perfect.
Okay, thank you. Sorry about that. Next slide, please. Thank you, Anna. Thank you, Lisa. And thank you all for joining us today. We're thrilled to hear more from our panelists, but before we dive in, I'd like to briefly review what brought us here. In 2018, the WHO released the NQPS handbook, which introduced critical elements needed to create an NQPS. Those are shared on the screen here. The handbook also describes how using these elements to create an NQPS is exceedingly important when trying to embed quality in all levels of the healthcare system. Having an NQPS can first create a culture shift that supports providers to deliver and users to demand high quality care. It can bring together multiple quality initiatives under a systematic and organized effort to improve quality of care across the healthcare system. It can secure high-level commitment to quality through stakeholder engagement and consensus building to deliver on national health objectives. And finally, it can clarify structures of governance, accountability, and monitoring of the national quality efforts. Next slide, please. Shortly after the NQPS handbook was released, LHSS conducted our own analysis comparing the governance frameworks that Lisa introduced in the previous section. The final analytical lens included the critical elements identified in the WHO NQPS handbook, and it introduced two additional elements that we felt were critical when moving from planning to action. These elements are highlighted in yellow on this slide. First, continuous quality improvement, which is part of the Joseph Duran trilogy for quality planning, but not the focus of this brief. And second, financing. As part of the original study, we conducted a literature review of publicly available NQPS documents and conducted a global survey. The LHSS study had a broader definition of financing quality, which incorporated the interrelationship between healthcare purchasing mechanisms and the quality of care delivered, including incentives, fraud, waste, and abuse. However, the spotlight brief and this webinar focus on the practical need to cost an NQPS and ensure there is reliable funding to complete the associated activities. And with that, I would like to move on to our discussion questions and hear more from our panelists. Next slide, please. So welcome, Dr. Muruganzwa, and I believe Dr. Flomo is still getting connected. Well, thank you so much for joining us today. I'd like to pose our first discussion question to you. How can we create a costed quality plan or strategy for all of the work happening across the country? And Dr. Muruganzwa, why don't you go ahead and take us away?
Well, thank you, Morgan. Let me try to show my face. To try and respond to your question, how can you create a costed quality plan or strategy for all the work happening across the country? I believe planning together is very key, as well as having policies and strategic plans in place to guide everyone who's working on whether it's clinical services or any other supporting services to the clinical work to really focus on quality. For example, I can share what Rwanda has been doing for the past decade. The Ministry of Health is the lead to develop these policies, but also it has been really a key partner to leverage all the partnerships to make sure that everyone understands the quality we need in our clinical services or healthcare system, but also try to take the lead and guide all the partners. So every year we know what are the priorities for the Ministry of Health, which are shared with all the NGOs or any other stakeholder who's working in the healthcare sector. And from there, as partners, most of the times we also have our own priorities, but we have to come to the same table and align our priorities together before we start implementing activities. But also what the Ministry of Health has done well was to create technical working groups where we come together, either like every quarter, sometimes we have to have ad hoc meetings, but these rarely happen, but also they happen for a good reason, where partners, for example, we have reproductive, maternal, newborn and child health, big technical working group that meets sometimes twice a year. But we have, when we come together, we share each organization's activities, challenges, we troubleshoot all those challenges together. And I believe that has really helped not only the Ministry of Health know who's implementing what and where and what are the challenges, and have also created that space for everyone to be able to coordinate together and support the ministry as we should, or also the ministry requires. Back to you, Megan.
Thank you so much. It's so important not only to have everyone at the table, but know really where they're coming from and what's going on. Dr. Flomo, I know you had some issues connecting. Can you try coming off mute and weighing in on our first question? And it looks like your line is still muted if you're speaking.
Thank you so much. Can you hear me now?
Perfect.
Yeah, thank you so much. I'm sorry for the technical issue I had. I have to join later. Yeah, so going to your question, in Liberia, we've been able to create a cluster quality plan. Firstly, by assessing the current quality needs. So we have been able to conduct various supervision and conducted surveys to be able to ascertain what quality needs we have. For example, we've been able to use the EJISS, it's the Electronic Joint Integrated Supportive Supervision that assesses 16 to 17 thematic areas in healthcare delivery. So based on the reports, we now will know the priority areas that we should focus on. And that will also help us now to create a cluster plan. And then the next thing we've been able to do is to set a clear goals, and objectives. So in Liberia, we have very high maternal mortality. Maternal mortality is an issue here. So it's one of our targeted goals to reduce maternal mortality. We also have the effects of infectious diseases, malaria, COVID, Ebola, etc. So we've been able to set that goal, and that has also been able to help us in costing our quality plan. The next is having done all of these, we also engage stakeholders because stakeholders are our partners. So we want to map our stakeholders to know which ones are doing which work in certain areas so that we know exactly what they are doing. And lastly, you cannot cost without proper allocation of the resources you have. So we've been able to actually allocate our resources consciously, especially a low income country that are mostly donor dependent. So you must be able to cost allocate your resources based on your priorities so that you cannot run out of the limited resources you already have, and you want to create higher impact with the resources you'll be having. So those are ways that we've been able to create a cluster quality plan or strategy. Over. Thank you.
Thank you, Dr. Flomo. Yeah, something that you said when we spoke earlier has always stuck with me is that you cannot cost an NQPS or a strategy without proper allocation and knowledge of the resources available.
Yeah.
And I think that's very true. Absolutely. Thank you both. Wonderful. With that, I would like to transition to our second question. How can we maximize internal and external resources to support quality and reduce reliance on external resources? So Christine, why don't you take us away first again?
Thanks, Morgan. Let me try to respond to this question using another example from Rwanda. So we combined performance-based financing and accreditation efforts to provide comprehensive support to health facilities to improve quality of healthcare services a few years ago. And that decision came from an assessment that was conducted trying to understand the best way to use the real resources we have effectively. And so what used to happen before this merge, there will be two teams coming from the Ministry of Health or an independent partner who will be visiting hospitals, but they will be there like in two teams separately, which wasn't really a good use of either the hospital team or the evaluators team time, but also there was no clear link necessary about how the two teams work together. And the feedback from the health facilities was that they didn't feel like they had enough time to work on the recommendations from either team. But also, of course, the resources were double. And then after the merge, one team was able to conduct accreditation, but also the hospital teams are now being awarded according to their targets. So that has created a resource reallocation, but also has created a culture where people know, oh, okay, it's not only me who's required to do the quality. If my department doesn't do well, it's going to affect the overall score of the hospital, and my colleagues won't get their PBS. So no one wants to feel responsible for that. It's not a blame, but you don't want to feel like you let your workmates down in that way. So now our focus has been, on improving the standard of through accreditation, but also making sure that teams or the hospital departments are growing together, but also trying to make sure that the little resources we have can be leveraged to do not only one or two things well, feasible or possible. Back to you, Maureen.
Thank you, Dr. Mudaganzwa. And something that you said when we spoke previously too that stood out with me, I wonder if you could speak more to it now, was when you're talking about quality plan development and how decision-making really comes directly from the data. Can you just say more about how data is used when trying to allocate funding and determining if you look internally or externally?
Definitely. Thank you for that reminder. So we're trying to make sure that everyone, whether you're a nurse, a midwife, or a doctor, or a clerk, you really understand the importance of data. Because what used to happen again a few years ago was that you'll see medical doctors or nurses filling out patient information, but then the reporting or any other quality assessments was left to data managers. And you're trying to move away from that system, have those who collect data understand what they are feeding out, but also have them be the ones to take the lead on, oh, this hasn't been done well, so we need to improve on this, because we're trying to also see how we have some data systems, but how are they talking to each other? For example, we have district health units where we have partners come together to review data on a quarterly basis, but what are hospitals doing to inform or take decisions based on what was presented at the district, or even within the hospital department? How does the maternity improve their outcomes while they also need to work with logistics or supply for essential medications? So that has been sort of the culture that's being now, we're trying to focus on that becoming more like a habit so that people can know, oh, okay, if we do well, again, this is also under accreditation. If quality improvements from this unit can bring up the targets or can improve our patient outcomes while we have worked together with the supply chain for essential medications, that's already 2 units or departments of the hospital that are doing well. That's more PBF, but also that's quality that's being improved. Back to you, Morgan.
Thank you. I appreciate that. Absolutely. And Dr. Flomo, over to you. How can we maximize internal and external resources to support quality and reduce reliance on external resources?
Yeah, so thank you again, Morgan. In Liberia, we've been able to prioritize, trying to prioritize domestic funding. And what it means is that we are working through, for instance, the PBF, the performance-based finance, and we have the FARA, the fixed amount reimbursement agreement, or we call it the G2G funding. So it's usually supported by USAID, but then there are targeted deliverables that once the government of Liberia or the health sector achieves, they're being reimbursed by USAID, and then that funding can be used to improve other quality areas in health. So we've been able to scale that up. We're in many counties now. Initially started with fewer counties, but then we have now scaled up to 6 to 8 counties, and it's working well. And then for the PBF, how it works is healthcare provider and health facilities are compensated based on their performances in various areas. And then the funding either come from government, it comes from NGO, it comes from civil-based organization. Sometimes they enter contract with the CHT, the county health team. A facility may enter contract with the county health team to say, okay, if you improve this quality of care, you're going to achieve this, you're going to get a bonus, etc. So we've been able to scale that up, and it's working really well in Liberia. Next, I intend to introduce is minimum fee payment, because as it stands currently, all public facilities in Liberia health facilities are free. So we've been able to try to see how we can at least attach minimum fees so that the fees that will be collected will be used to improve all healthcare quality areas. We now have been also able to engage, build a public-private partnership, because in Liberia we have so many entities, companies. For instance, we have Firestone, we have LAC, we have all of concession companies that are working. So sometimes those counties that they are investing or they are based in, the government of Liberia most time enter an agreement that, okay, you'll be able to support healthcare, you'll be able to provide people in a particular locality, since that's where your concession agreement covers. So that alone helps the government of Liberia to save funding to also apply that funding to other urgent health issues. Because as I speak, Liberia is a low-income country, and then being a low-income country, it has a very limited health budget, and so we prioritize our health needs so well and engage other stakeholders, collaborate with public and private entities, churches, concession companies, etc., to be able to see how best they can help us with some of our health needs, and that has been working so well. We've been able to reduce maternal mortality. In 2013, we had a maternal mortality of 1072 per 100,000 live births. Currently, we are now moving towards 500 per 100,000 live births. And our malaria cases and malaria deaths have also been reduced. In addition with COVID and then HIV/AIDS and Ebola, and these are all been due to these activities I've just listed: engaging public-private partnership, collaborating, the PBF, the G2G funding or FARA funding, and then trying to at least establish a minimum fee where healthcare workers or people who seek healthcare will be paying those fees to be able to at least boost the quality of care across the country. Over to you, Morgan.
That's wonderful, Dr. Flomo. Thank you very much. Yeah, there's a lot needed that to support this kind of embedding quality at all levels. That was wonderful. Thank you. And for our last panelist, or our last discussion question up here, when we're specifically thinking about accountability, what are the most important considerations to create a plan that really does span from the national level to the front lines? And Dr. Mudaganzwa, why don't you go ahead and take us away again first?
Oh, thank you, Morgan. Thinking in terms of accountability, I believe the most important consideration for us to create a plan that truly spans from the national level to the lowest healthcare facilities, or where we provide primary healthcare, I believe, is to have clear roles and responsibilities from the national level all the way to the lowest health facilities, where the ministries of health have or develop policies and strategic plans and guidelines, protocols, and all that, but also hospitals that are implementing these guidelines have clear guidance on what needs to be done, and also having clear communication channels so that there is not only the top-down communication channels, but also the bottom can also communicate what's happening up to the top. I believe those two are really essential. And I also think having healthcare systems that I'm not saying that that they should be clear, easy to navigate, but at least know, for example, what are the packages of healthcare services at the national level, at district or provincial hospitals, at health facilities, as well as at the health centers or health posts, so that people know what to expect, but also how best to package the services that each health facility should be able to deliver or provide. And another thing is also the use of data. Data is very key for the ministry to prioritize, but also throughout that channel of communication, everyone needs to know, oh, okay, if we're receiving more patients with malaria, what do we do? How to plan for that? Or where are we seeing most of the patients? For example, in Rwanda, we know that about 80% of maternal newborn child health medical conditions are seen at health centers and district hospitals. Only the 20% remaining will be able to get to district hospitals and tertiary hospitals. And that's where we have more specialties, even though we need to improve on those services, but at least we also know where we can find most of the medical conditions, how are people presenting, and what can we improve to make sure that people are getting the best quality of services at any of those levels. Back to you, Morgan.
Wonderful, thank you. Yeah, that really did span the whole journey from the national to the front lines, and appreciate that. Dr. Flomo, over to you.
Thank you, Morgan. So, firstly, I would say to the most important consideration to create a plan that truly spans from the national level to the front lines will be firstly setting clear goals and objectives. So, if you don't have a targeted goal that you want to achieve, or if you don't have an objective that you want to have or achieve, it will be very hard, to create a plan that truly spans. And if you set goals that are measurable for healthcare quality improvement, goals that are specific, that are achievable, and align with the national healthcare strategy, you can be able to now create an accountability if those goals are not met, because you have a clear, indicator to track against these goals. You'll know what to try against. So that's the first step. And in Liberia, we've been able to set goals. We have various goals. Take, for instance, during the Ebola crisis in Liberia, our goal was to eliminate Ebola and then to also create a national infection control plan or guidelines. And we're able to achieve that goal, disseminating all of the national infection prevention control guidelines to health facilities across the country. We're also able to, for instance, develop the national IPC strategic plan. And that national IPC strategic plan has been able to help us in identifying our needs when it comes to infection prevention and control. And we've been able to adequately respond to epidemic, like, for instance, COVID-19. We're able to respond to COVID-19 adequately as compared to Ebola, when we did not have a clear goal prior to the Ebola crisis. The next thing that we may want to consider is our data collection and reporting system, because if we collect the rightful data and if we report the rightful data, I believe we will be able to be accountable for that. We'll be able to hold people accountable for the numbers. For instance, if there's an increased maternal mortality, what's causing that increment? If we have limited IPC supplies, for instance, in healthcare facilities, what are the causes? So we do that through data collection. And how do we collect data? We do that through supportive supervisions. We do that through audits. For instance, we have the ETISs, like I mentioned. We have the hand hygiene audit that we conduct. We have various supervisions that we do across various level of healthcare quality in various areas. So those data, once they are accurately collected, they inform stakeholders and they are accessible to stakeholders. And then we have now transparency in reporting. And then we hold individual accountable, we hold institutional accountable for probably not achieving certain goals, through those data. And next is we have established regulatory bodies and roles and responsibilities. So we have the Nursing and Midwifery Board, we have the Liberia Medical Dental Council that function in regulating, enforcing, some of the guidelines, healthcare quality guidelines and standards. So without these regulatory bodies, will not be able to be accountable enough to say, okay, if this goes wrong, what happens? What's the penalty for this? Who's accountable for this? So the regulatory bodies and their roles and responsibilities are very important in ensuring that we have a plan, for accountability in healthcare quality. And lastly, in Liberia, we've been able to set up something called the quality management teams across health facilities in the country. The quality management team is like a regulatory body that not a regulatory body to say, but it plays that role in the sense that it supervises, it has the responsibility to supervise healthcare workers in those facilities to ensure that they are adhering to better healthcare standards and principles and guidelines. So they have various compositions. They have medical doctors on the team. They have hygienists. They have nurses, midwives, PAs, pharmacists, etc. So that team has been able to do very well in coordinating quality activity across the health sector in Liberia. And then we've been able to develop open communication leadership because we think leadership is important. So we set up the quality management team to provide leadership and guidance to healthcare providers, healthcare workers, so that when something is going wrong, people can be accountable. And then we provide feedback to healthcare workers working in healthcare facilities. For instance, the HISS, when we go, we do the supervision, and then we come back after the findings. We go by and do mentorship and then provide feedback. Okay, for instance, you certain facility did not achieve their malaria target, or there was high IPC, high infection rate in certain facility, or high maternal mortality. So we say, okay, what's the cause? We found a gap. What can we do to address the gap? Okay, we need to mentor people, for instance, on use of the pathograph. Are they using the pathograph correctly? So then if that's the cause of that maternal death or maternal mortality, we go by and then try to mentor them on the use of the pathograph. Whatever cause it would be, we try to provide mentorship and then provide guidance and feedback to them. So we also been able to do continuous education and training because in healthcare setting, you have different diseases coming up, you have new knowledge coming up. So we continuously engage the healthcare workers, we continually train them in various aspects of healthcare quality. Thank you, Over Morgan.
Wonderful. Thank you, Dr. Flomo. And I put in the chat, but such a key point in the process is not only collecting the data, but also using it to provide that feedback to inform mentoring and coaching.
Right.
That's wonderful. Thank you. So now I believe we would like to move into some questions from our chat. And I'm seeing quite a few questions related to collecting data, using data, what types of indicators are being used. So why don't we start there? Dr. Mutagwanzwa, can you speak to some of the indicators that are used to inform quality in Rwanda and how those are collected? How frequently, what technologies, what mechanisms?
Thank you, Morgan. Oh, that's a big question. I will try to respond as best as I can. So
Yes, please.
most of the quality indicators we're collecting are, I believe, collected on they've become routine. So they are reported on every month through our health management information systems, HMIS. So we have HMIS for hospitals, and we have PISCOM for the community or community health workers. and there is also an exercise to integrate both systems so that they can speak to each other, because sometimes we used to have to check what is in HMIS and then also have to go and check what is in SysCom. That's one, and we sometimes also collect qualitative data on patient satisfaction to try and understand how are we really delivering care, or what's the quality of the services we are providing to patients. For example, I remember a quote from an assessment we conducted last year when we were conducting this study, where a healthcare provider or a client, I'm not sure who said that, but they said, we are happy when a mother delivers a healthy baby and she's also happy, but we don't necessarily go back and assess the process that got us to those best outcomes, if something we can continue or if there's something we need to improve. So, for example, that has been now taken over to try and we're trying to work on it under Respectful Maternity Care, which will have several indicators that are going to be added into accreditation. For example, I know we have a companion of choice indicator now. Sorry, I'm not sure I remember most of them, but if there is a follow-up, I can also look into HMIS and share a few of them. Does that answer the question, Morgan, a little bit?
Absolutely. Thank you. No, I appreciate it. I mean, I heard the national responsibility of embedding the HMIS or health management information systems at all levels and all the facilities, ensuring that the staff is trained and able to submit. And something that stood out to me was how important it is to build the data reporting into what you're already doing. It's really important to not add and really make quality a part of the system. So that, I think, answered the question beautifully. Thank you.
Thank you.
And Dr. Flomo, you spoke a little bit about this in your last answer, but anything you wanted to elaborate on in terms of the types of quality indicators that are used or how it's collected? You might be on mute if you're speaking.
Yeah, thank you, Morgan. So in Liberia, we have several quality indicators that we use. So for example, I spoke of the EGISS, the electronic joint indicator. Sorry, are you hearing me?
Yes, you're back.
Hello, Morgan?
Yes, can you hear me?
Hello?
Uh-oh, we might have lost you.
Can you hear me?
I can hear you. Can you hear us?
Yeah.
Wonderful.
Yeah, I'm here.
Okay.
I'm hearing you. I was not muted. Yes, I am. Yeah. So several quality indicators that we're using the EGISS tool, quality assessment tool. For instance, for our maternal health or maternal mortality, we are using how many patients or how many women attend antenatal care, and then we have various recordings that of women that attend antenatal care, women that have postpartum care, women that go for family planning, and then the number of babies probably that would die while assessing, maternal care. And then for infection prevention and control, we have various indicators. We have, for instance, how many supplies are there for IPC, how many times do the IPC focal persons meet to have meetings, where they are meeting meetings, why there are plans, after the meetings have been had, and then how do they implement those plans, and how many beds are in particular hospital, the spaces among beds. Look at hand hygiene stations, how many hand hygiene stations are there. So when we go to malaria, we look at how many women have attending, pregnant women are attending ANC, are taking their malaria treatment, whether they are getting mosquito nets, uh, how many malaria deaths, etc. So we have various quality of care indicators that we're using. And then we've been able to transition from the paper-based assessment to the electronic-based assessment. And our health information system has been very pivotal in our transition. Currently, we have gadgets that we use to collect data, quality data across the country, data relating to the electronic joint integrated supportive supervision. And then those data collected are then sent to the DHIS tool, which we're still trying to work on currently. It's not fully functional. We have some issues. And once they are transmitted, they're then analyzed and then shared with stakeholders, and then we can be able to make decisions from the data collected. So as it is, that's how we have been working in addressing indicators when it comes to healthcare quality in Liberia. So there are so many indicators. You go to EPI has indicators, how many vaccines are there, how many vaccines have been cooled, how many vaccines are stocked out. So we have wide range of quality issues. Over.
Wonderful. Thank you. Dr. Flomo, I think you summarized it beautifully. It's a complicated issue that takes a complicated response to address.
Right.
I want to first thank our panelists for joining us. It was wonderful to hear more about your experiences working in Rwanda and Liberia. Thank you to the wonderful questions and engagement coming in the chat. Please take a chance to review the spotlight brief. I promise there are some responses to the questions in there. At this point, I would like to hand it over to Soji Teddy, who is the Vice President of Global Operations at the Institute for Healthcare Improvement, and invite him to share some reflections from work that he's seen in the field around NQPSs and specifically financing. Over to you, Soji.
Liberia and Rwanda. Thank you, Morgan. And I want to say thank you to our colleagues from Liberia and Rwanda for sharing their thoughts. And I suppose in some ways it points to the global shift towards centralizing quality in the conversations. And if you look at the NQPS framework put out by WHO and some of the framing by Lisa, as far as USAID is concerned, quality has really taken center stage, and many countries are responding in a wonderful way. As it relates to financing specifically, I believe that the work done by USAID and the LHSS really called out the important role that financing plays, because if you develop an elaborate strategy, but there is no clear financing mechanism to empower you to undertake the activities, then you more or less become paralyzed. And many countries are using quite a number of strategies to be able to pull some resources together to undertake these. The first is an interesting concept that I talk about as deprojectizing quality. So interestingly, you see that quality is no longer taken as a projectized activity, but funded within the routine health systems functions. So I'll give you an example. I believe that from Liberia, we heard about quality teams. It's not just teams at the facility level, but it's a whole governance structure where you see quality managers at facility level, the district level, the regional level, and then you have national quality officers. And these are not newly recruited officers, but existing team members paid for by the government whose roles are being redefined. And that's very important to have these officers in place. Another area is in strategic purchasing. So you find that in many of the countries, they have health insurance schemes, and as they are reimbursing a huge number of health facilities to leverage on the cost of the medicines, and then to also guarantee a certain level of safe and highly affordable medicines for the facility. So that's also another strategy that is being used. And then in a number of places, they are talking about standards-based approaches to improvement. So to be able to qualify for a national health insurance scheme, for example, one has to meet basic minimum standards. And so there's a certain function within the system that, yes, we are financing you, we are paying for your health workforce, but to be able to qualify, you need to be able to have a number of parameters in place. And that is also driving health systems to be able to attain some of the quality goals. Of course, that is not to say that the donor agencies do not and funders have no role to play. And I think the interesting observation that is coming through is that as countries develop and implement quality strategies, is bringing more visibility into the funders and players in the space. So it's no longer a question of funders focusing on their priorities. If you bring in financing mechanisms, it's about aligning them to priorities of the country, which in many cases would have been called out in their quality strategies. So recently I was at a Ghana quality conference, and you find out that to address wash issues, we have water aid that is coming in. USAID is driving a lot of activities. You would have the foundations, but basically all of them really working hard, JICA as well in it, to align themselves to the quality strategy and the activities that the country itself is prioritizing. So I think that it's been a good movement, and it's really good to hear some of the practical experiences shared from the implementation perspective from Liberia and then Rwanda. Over to you, Morgan.
Thank you so much, Soji. That was fantastic reflections at a high level and summary, and then also the specific examples of the impact and value. Thank you so much. And with that, I'll hand it back over to our partner, Lisa at USAID. Thank you.
Sorry, Lisa, you're on mute. Lisa, are you able to unmute? No. Okay.
All right, why don't we head to the next slide? I'd be happy to wrap
Yeah.
this up.
Okay. Sounds good. Thanks so much. Sorry
Thank
about
you,
that,
Lisa.
Lisa.
So as you heard from our panelists and from Soji today, it's a complicated issue that requires a whole lot of work at all levels of the healthcare system to address. That's why governance and accountability is so important in overseeing quality at the national level. Some of our key takeaways that we found during our research with the Spotlight Brief and as our wonderful conversations with our country experts are: be explicit, be very clear about what the goals are and what you mean. Leverage what already exists, and as much as you can, align those existing resources and purpose of the goals. Create feedback loops for sustainability. As we heard from Dr. Flomo in Liberia, it's not just about collecting data, but providing that feedback and opportunity for mentorship to improve. Another thing we heard from both Rwanda and Liberia is position people and institutions purposefully, making sure that there are folks that know how to use the tools, how to collect data and understand quality. In Liberia, they have the quality management teams. In Rwanda, they have folks stationed in every facility that are able to collect and report that quality data. Invest in standard assessments as much as possible. Rwanda is one of the first countries to have a fully digitized healthcare system, and that requires a lot of investment and alignment, as well as training to make sure that it's used successfully. And lastly, design for flexibility and adaptability as much as you can. Things like Ebola and the COVID-19 pandemic can't always be predicted, but having the systems in place that allows teams and institutions to respond to it is really what makes quality part of the system. I believe that's our last slide. Next slide, just to check. Yes, so please don't hesitate to refer back to this spotlight brief or the family of briefs. And thank you so much for joining us today. And to our panelists, our partners at APT and USAID. Thank you, everyone.
Thank you. Bye, everyone.
Thank you.